Good afternoon from Boston, and welcome to those of you in other time zones and from around the world joining us this afternoon for our annual Bioethics and Black History Month lecture. My name is Rebecca Brendel. I have the privilege of leading the Harvard Medical School Center for Bioethics. And as we get started, I wanted to say just a little bit about the history of our Black History Month collaboration with the National Center for Bioethics in Research and Healthcare at Tuskegee University. This lecture began in 2020 when we started a relationship under our former directors of our centers, Dr. Bob Trug at Harvard and Dr. Reuben Warren at Tuskegee, to try to figure out how bioethics could develop a dialogue and be a catalyst for centering the margins and those who had really not been voices that had not been included, especially Black voices, in the work of bioethics in academia, and really to address the ongoing disparities as the height of COVID-19 and other social challenges. And really what this work became was an exercise in creating a very deep between our centers and the people in those centers. And now the legacy of that collaboration, creating this trust through trustworthiness that Doctors Warren and Trug started, has become the legacy that Dr. David Hodge, as now the interim director of the National Center at Tuskegee, and I, as the director at Harvard, have inherited. And so I'm really honored today for this year's forum to turn our focus to Black history and bioethics and the legacy of the Tuskegee Report. I'm joined today by two esteemed colleagues for this conversation, Professors T.S. Harvey and David Augustin Hodge. Let me begin by introducing them. First, Dr. Hodge. David Hodge Sr. currently serves as interim director, lead ethicist, and research professor at the National Center for Bioethics in Research and Healthcare at Tuskegee University. He previously served as associate director of education at the National Center beginning in 2017, during which time he directed the center's bioethics honors program and bioethics minor for undergraduates, its annual public health ethics intensive course, and outreach programs to engage the center's target audiences. He teaches bioethics and public health ethics courses at Tuskegee. In addition to his administrative and academic duties, Dr. Hodge is a researcher, author, and editor. He is the editor of the center's Journal of Healthcare Sciences and Humanities, a peer-reviewed publication in partnership with the Smithsonian Institution's Office of Sponsored Programs. Before his current appointment, Dr. Hodge served as an adjunct assistant professor at Georgia State University and as a guest lecturer in philosophy, theology, and ethics at the Interdenominational Theologic Center in Atlanta, Georgia. He has also held teaching positions in religion and philosophy at Florida Memorial University, Nova Southeastern University, Broward College, Miami-Dade College, St. Thomas University, and Barry University, all in Southern Florida. A native of St. Thomas, U.S. Virgin Islands, Dr. Hodge's academic background includes a Bachelor of Arts in Bible, Theology, and English from American Baptist College of Tennessee, a Master of Arts degree in Education from Oral Roberts University, a Master of Theologic Studies degree from the Candler School of Theology at Emory University, a Doctor of Ministry degree from Columbia Theological Seminary in Atlanta, Georgia, and a PhD in philosophy from the University of Miami. Please also welcome Professor T.S. Harvey, who's an associate professor of medical and linguistic anthropology and global health at Vanderbilt University. One of the legacies of the Tuskegee Harvard bioethics collaboration these last 6 years has been the deliberate work to expand our framing and our community in the work of bioethics. And today, in welcoming our esteemed colleague, Professor Harvey, to this conversation, it serves both as an example of our growing relationships and community and our widening lens on the work of bioethics itself. And we're so honored to have him join us in this community. He is, as I mentioned, Associate Professor of Medical and Linguistic Anthropology and Global Health at Vanderbilt University. Dr. Harvey's research and interests focus on expanding scientific partnerships, developing innovative technologies, and building local capacity to tackle large-scale global public health and environmental challenges that emerge at the critical intersection of vulnerable populations, health disparities, disease, risk, environmental degradation, and water, sanitation, and infrastructure integrity. The evolution of this unique transdisciplinary approach is the product of more than a decade of funded collaborative research, capacity building work, and global engagement with a broad range of institutions and organizations, including the Environmental Protection Agency, the World Health Organization, the Ford Foundation, and the Robert Wood Johnson Foundation. And this collaborative work has been on a wide range of topics, but are not limited to cross-cultural doctor-patient communication, language and culture in global public health, waterborne diseases, enteric illnesses, disaster prevention and relief, neighborhood approaches to risk reduction, crisis management, sustainability, and resilience. Regarding really groundbreaking work that Dr. Harvey has done in technology, he led the team that created one of the nation's first virtual self-screening tools, which helped individuals assess their risk of being infected with COVID-19 and facilitated access to healthcare by directing users in real time to resources available in their areas. Most recently, in his role at the Vanderbilt Institute for Global Health, Dr. Harvey developed and designed a low-cost wearable medical device to increase prescription drug adherence globally. Please join me in welcoming Dr. Harvey and Dr. Hodge.
Thank you.
Now, really delighted to have you both with us. To set the stage for our conversation, we decided in preparing for our time together today to structure our conversation in 3 parts: past, present, and future, to really frame our engagement of the legacy of the Tuskegee Report, to understand where we're going, first to understand where we've been, where we are now, and what we see as the opportunities for the future. And as many challenges as we have ahead of us, we really want to think in a forward-looking way that also brings optimism to the many challenges, to the solutions to the many challenges that we're facing. So by way of introduction, so we can all come up to speed quickly, I got tasked with providing just a little bit of history as we get started. So when we think about the legacy of Tuskegee, what we're really talking about is that from 1932 to 1972, over 40 years, nearly 400 Black sharecroppers in Macon County, Alabama, were denied treatment for syphilis and followed and monitored by physicians employed by the United States Public Health Service. As part of this study, which was not really, had no therapeutic benefit and no aim of providing benefit, it was really designed to document the natural history of the disease. The men were told that they had bad blood, literal quote. In fact, what happened in the course of looking at the natural course of untreated syphilis, these men and the government officials who participated went to what the final report of the syphilis committee called, quote, extreme lengths to ensure that they received no therapy from any source. So in 1972, the New York Times reported that the Tuskegee syphilis study was, quote, the longest non-therapeutic experiment on human beings in medical history. Following this publication and the public exposure of these practices, there was a lot of attention, understandably, to lay out ethical principles for research with human subjects. And in 1978, after 4 years of work, a national commission of physicians, lawyers, and scientists released what is now known as the Belmont Report, which laid out ethical principles for research with human subjects. However, and what we're going to be talking about today is how we nonetheless have failed to recognize and to make progress that has had meaningful impact for Black Americans. 18 years after the publication of the Belmont Report, the Syphilis Study Legacy Committee in May of 1996 was completed, really looking at what the enduring legacy has been of the U.S. Public Health Service study. And quote this report, even nearly 2 decades later after the Belmont Report, quote, the study continues to cast a long shadow over the relationship between African Americans and the biomedical professions. It is argued that the study is a significant low participation of African Americans in clinical trials, organ donation efforts, and routine preventive care. In view of this, the committee came up with 2 specific recommendations. First, what became a recommended public apology by then President Bill Clinton, and also the need to address a systemic way of ensuring that there was strategies to redress the damages caused by this study. And central to the recommendations of how to do that was the establishment of what is now the National Center for Bioethics in Research and Healthcare at Tuskegee University. So here we are now. It's 30 years after the final report of the Syphilis Study Legacy Committee. And we know it's also more than 5 years after COVID-19 came upon us, and we again experienced major disparities in healthcare that was available, and the impact of, in that case, a global pandemic disproportionate on Black Americans and other Americans of color. And so now we turn in our bioethics and Black history conversation today to really understand the ongoing legacy of the Tuskegee Report, what we need to do and ought to do to address that, and where we go in the future. So I'm going to start with Dr. Hodge and asking you that question, sort of where are we and what are the legacies that we see today of the U.S. Public Health Service syphilis study. But even more than that, just to sort of tee you up, you've advocated that we're both not where we, and that if we want to go where we have to be in terms of ensuring better health for every American, and in particular for Black Americans, that we need to actually change our ethics. And we need to change our ethics to what you've termed a distinctly Black bioethics. And tell us a little bit about what that looks like and what it would achieve.
Thank you so much, Becca, and thanks, my dear brother, T.S. Harvey, and thank you, family, for allowing us. I just want to take just a couple of minutes and run through some slides that will show us something in a really recent conversation with Dr. Harvey. we've been having another group of colleagues. He mentioned T.S. Eliot, and this very famous statement by T.S. Eliot, which is there's always a past in the present. There's always a past in the present. Doesn't matter how much one may try to run away from the past, we're still living in that experience. This in the DNA, right? It's part of what we call ACEs, adverse childhood experiences, where in the DNA, in our structure, in our experiences, in our trauma, there exist these particulars that continues to keep Black and brown people where they are. So just for a few minutes, I just want to reflect on some of the present categories that continue to resist what seems to be best efforts. Next slide, please. First, when we talk about excess deaths, we're talking about those deaths of Black and brown people, particularly Black people, over and above their white counterparts. Next slide, please. This one, when we talk about the estimated lives lost, years of lives lost, given Blacks against their white counterparts, it adds up to about 80 million years of life that has been lost. 1.63 million lives lost per their group between 1999 and 2020. These are years that will never be gotten back. And this creates a gap in the conversation, not an abstract gap, but a preventable gap. Next, it's something that promotes or allows for funerals because Black people just keep dying at a faster rate. Next, Black and brown the life expectancy. Maternal mortality. The life expectancy, the maternal mortality rate shows that Black women are 3.5 times more likely to die in childbirth than their white counterparts. Next one, which is infant mortality. Infants are twice as likely to die than their white counterparts. Next slide, please. And all in all, in terms of all lives, we are Black. Look at this, the levels here. Black and brown people, well, particularly Black in this one, is still leading in the kinds of deaths that are preventable. All right, let's take that down, please. Take down the slide altogether. That's all I wanted to say. I just wanted to demonstrate evidence-based that there is a situation that continues long after the syphilis study that continues to demonstrate a lack of attention to Black lives and Black lived experiences. So when to the question, Becker, about where are we? First thing we got to admit that there's something deeply and profoundly wrong. You mentioned COVID-19 a moment ago, and we must ask the question, how did COVID-19 find Black people at a higher rate than it found any other people? How did COVID-19 know to go to Albany, Georgia, and say, well, I'm going to take the lives of these Black and brown people at a faster rate than other people? How did it know? Well, one of the ways that it knew to do this is because of comorbidities. Because of those excess death categories that I just mentioned, namely cardiovascular disease, hypertensive, cancer, HIV, etc., preventable deaths, right, violence and gun violence. Because of those excess deaths categories, it creates a vulnerability for Black people and brown people in such a way that whenever something like a COVID-19 catastrophe hits, that comorbidity becomes like a trimorbidity, right? You already have diabetes and hypertension, and now something else on top of it take you out. So I will just pause right there and just share that those are the kinds of things, if we do not give attention to Black lives and brown lives and lives that are vulnerable in public health, then we will see these kind of vulnerabilities act out in very traumatic ways down the line.
Okay, thank you so much. That was an incredibly important framing. I'm going to come back to what you come back to Belmont and Black bioethics in a minute. I'm going to give Professor Harvey an opportunity to respond to what you've said, and just to tee it up by saying that you've also, from the perspective of what you incidental anthropology, Dr. Harvey, really talked about the same kind of intersectionality, referring this Gordian knot of racism. Little did I know when we first met and I talked about the problem as a Gordian knot that I was, in fact, quite superficial in my analysis of the situation, and that you have given this really substantial thought, looking at the structural, institutional, and global factors that have really continued to affect Black lives to this day. So I'll give it to you, Dr. Harvey, for your first comment.
Thank you so much for teeing this up, and thank you for the opportunity, Dr. Hodge, to be invited to the conversation. So I would like to sort of echo some of the things that Dr. Hodge said, but to frame this in terms of thinking about the gaps and return to a conversation about the gaps. So oftentimes when we think about the Belmont report, which is sort of a global northern standard, because as we know, the Belmont exists in the shadow of Nuremberg. When we think about that, we think about a kind of strict constructionist view of that, which has really been a concern with, as it was written, bioethics as it relates to research with human subjects. But as Dr. Hodge points out, part of the short-sightedness of that is to look at the downstream implications of something like the Belmont report and its circumscribed limitations and preoccupations with what constitutes research with human subjects, and understanding the intersection between research with human subjects, for example, and clinical trials. Research with human subjects and, for example, biorepositories. Research with human subjects and, for example, public health. And so this brings us to a rather perplexing problem, and you can think about it in many ways. From the field of the arts and humanities, you could frame it as the Gordian knot, of course, a reference to Alexander. For those of you who've heard about the story of the Gordian knot, the idea is that you have this tangled mess that cannot be untangled. People have written classical pieces of music about it. Henry Purcell wrote a piece on the Gordian knot, but the idea is it's a complex problem that can't quite be untangled. And as the story goes, if you could come to this town and untangle this mythical knot, which you can think metaphorically relates to health disparities, health inequality, if you could manage to untangle that, right, somehow you'd be ruler. And this, of course, is connected to the myth of Alexander the Great. And the idea was that he came in and he didn't attempt to unravel it. He just cut it. But in public health terms, they don't talk about Gordian knot. They talk about wicked problems. And the idea here is a similar thing in a problem in which, it's so very difficult to define various pieces reaching in and out of it. And oftentimes what you hear is that it's complicated. But one of the things that we say in our research team is that to say that something is complicated is not an answer. It is a description. And so what we hope to do is to build beyond, right? And to think about as we reimagine Belmont under the framework of a Tuskegee report, reimagine the possibilities, to think about the complexity of the problems as human problems that have human solutions. So I'll stop there. Thank you for the question.
That's great. So two perspectives on this, right? Looking at the continuing gap and the continuing state of where we are when we look at public health and the lives of Black and Brown people, but also, and the global North, right? But also looking at this notion that we can't things complicated that's not going to, in and of itself, help us find the answer, right? It ought to push us further to finding answers and generating approaches and solutions. So Dr. Harvey, you set us up really well in talking about some of the limitations of the Belmont report and how really it focused us in ways that were strictly applied to bioethics and research on human subjects in particular ways. And Dr. Hodge, you in your work have talked about that as well, about how the principlist ideas in the Belmont report aren't really what we need right now, that we need a different kind of bioethics. Do you want to tell us about why that is and about your conception of Black bioethics and what that means and how it would help us not just describe a problem, but actually generate solutions?
Thank you very much. And please call me David. Mama named me David, and I like hearing David. David means beloved, so I like hearing it. And thank you, TS, because that really does a great job in taking me to how to define Black bioethics. There's always a discomfort in lending and giving these adjectives to things, because one would always ask, like, why call it Black bioethics? And how is that? Is that a pigmentation thing? And I've always not thought of it as a pigmentation thing. I've always looked at it as a protest thing. The way in which Blackness came about in the understanding of Blackness, so what some understandings of Blackness meant through the 60s, that brought about Black theology, for example, with James Cone and J.D. Otis Roberts in the 60s and the 70s, as a way of thinking about how to deal with the exclusion of Black people in the field of theology, and thus the field of sociology and the social sciences, right? How do we make it known that liberation theology, it should be an important factor in how Black people think about things? And this was done, interestingly, in partnership with the Latin American theologians, Gustavo Gutierrez, and a host of them, Segundo and such. So now, so my taking back of the term Black from Black theology is how I'm using it, because it encourages and it motivates, and it's inclusive rather than exclusive. It says that I am just as interested in, as a Black bioethicist, I'm just as interested in our Native American populations. I'm just as interested in the Alaskan or Asian Pacific populations. I'm just as interested in my Hispanic brothers down on the border, the Mexican brothers and sisters, or the Cuban brothers and sisters, any such thing, as I'm interested in those in the Appalachian Mountains. Right? Those who are poor, because quite frankly, when we're talking about ethics and when we talk about principles, we are talking about the least, the lost, and the left out. We're talking about people who are vulnerable and they cannot fight for themselves. And that's why Blackness is so important, because Blackness then becomes a metaphor for what it means to not be able to fight for oneself without some advocacy from others. So Black bioethics is not simply about pigmentation. That would be reductionist. It's about identification. How do you identify with people who are the least, the lost, and left out? Well, because populations, that was what public health is about, populations, but bioethics is about individuals. And if those two are not conversational, then we miss something extremely important. It is not sufficient to speak only in terms of public health and populations, because populations are made up of individuals. And individuals are made up of all kinds, including least, lost, and left out, poor people, brown people, Latinos, Campesinos, the whole gamut. So that's what Black bioethics is. And just to touch on something that you said in your questioning, Becca, with respect to, like, how does this jibe with the Belmont report? We are not in any way interested in the rejection of the Belmont report. The Belmont report has done and continues to do what it was designed to do. It was a research formula to ensure that certain protections were in place. We asked the questions, protection for whom? We asked the question that mainstream bioethics may not be asking. And that's why, again, Black bioethics. So the Tuskegee Report is less interested, for example, on just justice, is interested in social justice. Correct? See, we're not, when we talk about respect for person, we're talking about agency more than we talk about autonomy. When we're talking about beneficence, the movement from benevolence to beneficence have already been established. But we are saying, unless there's another step, that is the notion of empathy and care, to ensure that beneficence take on real value for the least, the lost, and the left out, then we're still rhetoric, right? We're still rapping. We're not really engaging.
Thanks. That's incredibly clear and helpful, and that what we're talking about. One of the legacies of the Tuskegee Report then is really how we continue to center the margins in very important ways, both around public health, but individual health as well. Dr. Harvey, so I should say, I think it's obvious to everybody the affection I've had for a long time for you, Dr. David Hodge, and my new colleague, Dr. T.S. Harvey. I'm being formal only so that I don't slip and forget that we have hundreds of people in attendance watching this, and that this is going to be on the internet. And we hope hundreds and thousands more join us in this critically important conversation. So it's out of the utmost of respect and affection that I'm so formal to make sure I can put forward this work in the most important. So with that being said, Dr. Harvey, when you think about this in a global context, you've also brought other pieces, right? Not just from individual populations and individual lives, but the environmental, the structural, the institutional factors that really affect disparities, not just in health, but disparities in life. Because as Dr. Hodge has showed us, if one begins life with a foreshortened expectation of what that's going to be, it very much affects the conditions and one's circumstances from the very beginning. So I'll let you tell us a little bit about how you've approached this inheritance, this legacy, and what directions you see that we need to go.
Yes, absolutely. And so my colleague on our current Robert Wood Johnson Foundation grant is Ted Fisher, who's not with us today. But part of that grant is under the unit that essentially looks at global solutions for U.S. problems. And what we wanted to do as we thought about the challenges and opportunities in bioethics is not to limit that discussion to examples of what we know has happened in the U.S. historically. And not also to just look abroad for other examples of atrocities, but to recognize that these challenges are shared and to look beyond our borders, to think through the ways in which perhaps other populations, other universities, other researchers have grappled with similar problems, to think through the ways in which, for example, you can reimagine bioethics around research with human subjects, a way that brings vulnerable populations, the populations that my colleague Dr. Hodge mentions, the least, the lost, the left behind. How do you bring them to the discussion, but not at the end, not as an add-on or a footnote, but how do you bring them in to reimagine what bioethics could be? Right. And in order to do that, of course, you have to get out of the sort of framework and the shadow of Belmont, and also out of the sort of the Western hubris that somehow we're the only ones who have a notion of ethics, right? Which is why I think my colleagues' framing of this under the auspices of care ethics allows us to think about that in a broader context, and to allow those other models, indigenous models, for example, to inform the ways we think about, for example, consent, the ways we think about what constitutes a community, how long consent is good for, the ways in which we think about autonomy, who has autonomy, what does autonomy presuppose, notions of justice, to the degree to which benefits versus risk, all of these things can benefit from a framing and a thinking about this in a way that engages impacted communities to rethink from construction up the way we reimagined what bioethics could be under this Tuskegee report that we're building.
So, so many pieces to what you've just said. Let me see if I can highlight some of the salient features to move us ahead. But a bioethics that moves not from the top down and from abstract ideas and principles, but a bioethics that's embodied and informed by the voices and the lived experience of those who would be affected either by existing challenges or by future interventions. And also this notion of what it means to respect dignity and be an autonomous agent is one that must be framed in the context of care and community and relationality, and not in thinking about individuals as isolated or isolated or separated from the context, the people, the relationships, and the circumstances in which we found ourselves. And that if we really reimagine that, what we'd be looking at, or the big change would be not to start with our own limited Western answers, right, to global challenges, but rather to open up our minds and open up not just our minds, though, our hearts as well, to be engaging these problems from the perspectives of those whose voices have been either not heard or even actively silenced. So critical things to think about. And when we think about the fact that 60% of the world's population lives in a lower middle income country, right? To think about a bioethics that comes from these high income centralized or abstract notions, we begin to see really how much of a mismatch that is. So I want to turn to so many more questions I can ask, and I'm also mindful that I have you both only for a short period of time. But I'm particularly want to invite you, Dr. Harvey, to talk to us a little bit about how you've bridged the use of technology and some of these innovations to begin with the in the community, to begin with the lives and the stories of individuals to address problems on an individual and a public health scale, as opposed to from the top down. I mentioned in your introduction about the innovation to locate treatment for COVID-19. We talked about a wearable device. How do you see that intersection as bringing us forward in making, in imagining a new bioethics and new commitment to the lives of persons?
Yeah, thanks for the question. And I just want to sort of, pivot back to Dr. Hodge's comments in terms of where we start, right? So how we approach these problems, whether we call them wicked problems or Gordian knot, right? If we approach them from impacted communities, then the way we design and imagine interventions and who we imagine and design those interventions with gets defined by where we start, right? And so understanding the problem, and Dr. Hodge has done a lot of work in this at the National Institute for Bioethics and Healthcare, sort of understanding the problem, sort of not setting out, for example, to answer the problem that you hope is the central issue, right? And sort of engaging with interlocutors and communities to understand those perspectives, specifically in the area of research with human subjects. We can think about organ transplantation. We can think about all sorts of spaces that are informed by engaging directly with those communities. And so that kind of interdisciplinary approach, which I think is grounded in anthropology, which is an interdisciplinary social science, sort of lends this ability to think not just horizontally, but also to think about the ways in which one needs to connect these sort of propositions and abstract ideas of principles and guidelines, which exist sort of, if you will, metaphorically in the penthouse, that those ideas have to travel to the basement, to the ground, and it has to be informed in some cases, right, by what's happening on the ground. And otherwise, again, we are essentially solving problems that are not actually there. And so what I've sought to do in many aspects of the work is to build collaborations, transdisciplinary collaborations around a problem, to bring people to the table that have disparate expertise, right? To dismantle the silos that get in the way of working together on these sorts of problems. Something that my colleague has done consistently in terms of the ways in which he thinks through these problems and frames them.
So maybe this could be to either one of you, but what I, of course, jumped to the solutions immediately, or what we need to do about it. But you're reminding me that I wanted to get out of the hot seat of thinking about the history too quickly, because actually what we need to be doing, even especially now in the present, before looking for not just redefining the problems, but also redefining the way in which we identify the problems that we want to address. So that's very, very helpful. I feel like my wings are a tiny little bit clipped, and in a very good way. I feel that's a very really transformative way of thinking about this. So as usual, having the privilege of being here, I've clearly already learned more than I've been able to contribute. Dr. Hodge, what would you say to us about that? So when we think about this through the lens of the least, the lost, and the left behind, how does that change the way we frame what we need to be focused on and how we do our work?
Thank you so much. I was thinking as TS was speaking about a couple of years ago, I was invited to a conversation at MIT, and I learned something new. I just recently learned this ChatGPT thing, right? That was fascinating to me. And then I learned, so there they asked the question, do you know how this works? And so that's around the table, and we all came up with something, and we were all wrong. And he said, AI technology, especially ChatGPT, et cetera, works by anticipating the next word. I didn't know that. So now immediately my question is, whose next word? Right? Where did you get that next word from? Because if I'm not in the conversation, I'm from the Virgin Islands. My next word will be something like, what are you, man? Right? That's my next word, right? Yours might be, what's wrong with you? What's wrong with y'all? So there is a misstep if we do not understand or start to work with the power of implicit bias and biases in innovation and in technology, we will continue to go down the road of excising those communities that need to be involved. At what point did grandma's voice become the next word? When was her voice included in this technological thing? One of the things that we're doing in our research with our family at Vanderbilt is we are looking at how in technology, how exclusion occurs not by racism, but by comfort zones. I had opportunity to work with some brilliant folk at Case Western who developed some brilliant technology, and in terms of prosthetics, and the person who was the clinical trial recipient was a white guy, very nice guy. I really enjoyed him. We cried a lot. We shed a lot of tears thinking about how he lost his arm and how that technology gave him an opportunity to feel his wife and his children's physical hand again. Very emotional. But see, my brother also lost his arm in a motorcycle accident. So my question was, why wasn't my brother included in the clinical trials? And so it was not that that Black and brown people were excluded. It's just that what was closer, it had to do with proximity. That's why care ethics is so important, because it's relational. It has to do with proximity, right? If you have a relationship with someone next door, someone down the street, you will say, "Oh, Hodge, his brother, he lost his arm." And so, therefore, when we're talking about clinical trials, we're talking about one of clinical trials and Black bioethics and the Tuskegee Report. We're talking about making the invisible visible. How do we lift the veil, which is very symbolic at Tuskegee, coming to Tuskegee Gate, and there's a Booker T. Washington lifting the veil of a former slave. How do you lift the veil? How do you make it such that people who are unseen can be seen? I'll give one way, and then I'll move on. And that is, one way to do it is that find ways to include family members in the conversation of clinical trials before they get to the deathbed. My predecessor and my mentor and my brilliant colleague, Dr. Reuben Warren, he taught me so much along these lines. When we're doing clinical trials and we wait until a person is in their deathbed and offer them an informed consent document that reads like a PhD dissertation and say, "Sign this," what are you going to do? So therefore, to get to the least the lost and left out, and if we're going to deal fairly, ethically, and caringly with communities and engaging with communities, then we need to be serious and we need to be authentic, and we do not wait until a person is out of choices to say, "Here's a choice."
Okay, so so much there. Dr. Harvey, how do we do that? How do we create choices? How do we bring in lives and voices that matter before we're at the time that we're thinking about our innovations, our possibilities, and not when we're looking for last-ditch efforts, as Dr. Hodge has so eloquently laid out?
Yeah, that's a good question. I think just to go back to a point that was made earlier, there's a recognition that technology, for all of its capabilities, whether or not we're talking about artificial intelligence, large language models, or really sophisticated prosthetics, technology is not neutral. And I think one of the things that needs to sort of be acknowledged is that it's not neutral. In many cases, it replicates existing structures, existing notions. And so when Dr. Hodge talks about the veil, one of the things I think about is to mark the unmarked category. And so to think about prosthetics and to look at for example, who the intended recipients are, right? And so for many, many years, prosthetics disproportionately went to veterans because of all of the wars. But now we realize, that many of the amputations now are associated with diabetes. And so how do we reimagine who the recipients are? How do we reimagine deservingness, right? And so this has to be more than something that we add on. Dr. Hodge likes to joke about someone who once said, who will not be named here, said, put a little ethics on it, right? Put a little bioethics on it. And so the idea here is that this is not something that we add on. This is something that we rethink. So we rethink, right? So for example, people say, well, why Black bioethics, right? As if the Belmont report in and of itself is like a version of McDonald's. McDonald's is ethnic food. The Belmont report is marked. And so part of what you have to do is to think about how the unmarked sort of prefigures a certain set of expectations about deservingness. And so as we go back and as we move out, we think about health disparities and who, who are the populations that are impacted now, and then reimagine those technologies and reimagine those interventions by understanding those challenges. But to do that, we have to move beyond utilitarian ethics to what Dr. David Hodge talks about as fundamentally relational, right? And this has been thought about in many, many different ways. The philosopher Levinas talks about an encounter with a face, right? And sort of what he suggests is that the first thing that one must do when one encounters a face, this is Emmanuel Levinas, is that there's recognition, right? Recognition has to come first. Recognition becomes before relationality. So we can use many, many different philosophical frames to think this through, but we need to, again, recognize that technology is there as an aid and can be used in many, many ways, right? But also understand the kinds of disparities that some of these technologies reproduce, as Dr. Hodge mentioned. I mean, when you're thinking about large language models, who were these models trained on? When you think about soft AI, for example, in something like Microsoft Word and the editing out, for example, of the ways in which people hedge, right? It edits that out so that the voice sounds more masculine, which is a projection of authority. Now, I'm a linguist as well. And what does that look like when a woman is using, for example, Microsoft Word and is editing out the kinds of phrases that allows one to position oneself as less than an authority, and then that gets sent out. And of course, in the context of depending on who sends it, right, it then gets read as someone who is, for example, overly controlling or someone who is overconfident. So technology is not neutral. Right. And so rethinking the way in which we approach it, the way in which we use it, that the response is not to kind of cast it aside. It's to reimagine it, understanding its complexity, understanding the possibilities as well as the limitations.
Can I add something that you just piqued my brain, because this embedded in the models and embedded in what you said over Microsoft Word or soft models is then a chance for misogyny to prevail. And if misogyny can prevail and other kinds of discriminatory practices can prevail, then what else is being prevalent in conversations? And our young people then have to use this kind of technology, and they may not realize to what extent things are bought into ahead of them, or what kind of ethics are embedded or being shared. One of the TS just mentioned this reimagining how prosthetics are used and for whom. And one of the things that is just so interesting to me is that the technology to get that done, TS, is going to require a lot of money, right? Lots and lots of money. It's in the hands, the money's in the hands of gamers. The technology is in the hand of gamers. So there has to now be partnership with gaming communities, right, and gaming companies to see to what extent that partnership could bring about some kind of healthcare for those persons who really need it. Because again, remember, in every state in the country, Blacks lead in either excess deaths or the population lead in disparities in every state in the country. So if that is in fact the case, then one could determine from that a large portion of those who have amputations are Black and brown people, right? The same thing is true with kidneys. A large portion of those who need kidney transplants right now are overarchingly Black people. So then who gets that transplant? And how does that work? And how do you pay for it? Because a porcine transplant or a pig kidney into a human, which may have the life expectancy of about 5 years, and it costs $150,000 to do, then how does that work when there's a kind of financial bankrupt in the healthcare system? So back to the Gordian knot, right? So now you take something complex and you make it even more and more complex. And unless and we go back to our ethics, why a particular brand of ethics undergirds this and mitigates some of this other stuff, because it says that relationships matters, caring about people matters, and is driven by empathy. Empathy is the capacity to understand what somebody is going through. Caring is how you respond to that. Compassion is how you respond to that. You see? Okay, that's it.
All right, so I'm going to bring this sort of back to a few responses to that. One, Professor Harvey, when you said that technology is not neutral, it replicates existing structures. I would take that even a little bit further to say that that not only does it replicate existing structures, that it can actually magnify and amplify the disparities that occur as a result of the existing structures. And that really, if we take this notion seriously of centering the margins, we would get out of thinking about health as just the kind of healthcare that we deliver, and really embrace what Dr. Hodge is talking about here, and think about some of the models of community health interventions that have been very effective in communities, in particular in the global South, at beginning not with the high-level professionals, but even showing incredibly powerful results around health and mental health, right, with community health workers, right, or and not overly beginning with our connectedness and our relationships with each other, rather than with the biggest science or the highest training or technical knowledge that we have, right? So really embracing this notion of care, relationality, recognition, and empathy as a precursor to anything that we would do, whether it be our technology, as we seek to use this technology towards a positive future that would close these health gaps and beyond closing the gaps, advance the health of those who have been left behind in particular. So we're down to our last few minutes already. I've asked about one of 100 questions that we could talk about that I had hoped we'd engage today. So I hope we can do this again. We've had a lot of questions both before from attendees and coming in throughout our time together, and one really sticks with me. And so the question comes from a young person thinking about a future career, one that embraces bioethics and committed to advancing health in clinical trials and other interventions. What do we tell our young people? What would success look like? And how do we tell our young people or help inspire them about starting in a place so that in another generation and a half after this conversation, we're not still in the place that we are now, 30 years after the commission report? Anyone can go first or second. Lightning round answer to another, if not a wicked problem, a wicked Gordian question.
Okay, I'll go first, and I'll make it quick. That's something Becky heard me say time and time again, and my dear brother Lachlan Foro, who I'm sure is listening in, that there's right now a 13-year-old girl in Kenya, or in Ukraine, or in Guatemala, or in Tuskegee, or a 13-year-old girl anywhere whom I do not know, but she's my sister. And I have to keep this girl or this boy, it's a metaphor, right? I have to keep this person right at the beginning of my head each and every day, that I cannot take time off beyond what's reasonable, right? But I can't just stop thinking about them, because the time is going to come when something I do here would affect where they are there. And I must continue to push. And so therefore, young people are thinking about this kind of work that is public health ethics and public health and bioethics, neuroethics, etc. It is important to engage. And it's sometimes you're working in the dark by yourself, but other times we're working in a community like we are right now.
Well, I think we certainly do our best work in community. right? And so that's one thing that I think can inspire young people to begin to talk about relationships, but to build them. And I think that that's been one of the legacies of our work together over the last 6 years, is making sure that we don't do this work in isolation and in silos, but that we build and change the nature and the scope and the possibilities of our relationships, for which I will forever be indebted to you and Dr. Rubin as our partners in. Professor Harvey, we give you the final words of encouragement and wisdom.
Yeah, so I guess I would just echo what's been said, but I'm thinking about Antonio Gramsci's pessimism of the intellect, right? And how the optimism of the will is stronger than the pessimism of the intellect. And I would say, as we are teaching students about these problems, the thing that we don't want to do, right, is to presuppose that just because previous generations didn't solve something, that there isn't a solution. We have to set aside our own hubris and our own understanding of the problems and open up the possibility that anyone sitting in the audience, any student, that they are just as likely to have a solution to something that is or would be intractable problem as the next person, and to engage that seriously, right? And to not sort of strap people with the burdens of the past. Understand those, but be willing to and able to and encourage them to, and to create an environment in which people can imagine alternative futures.
Thank you so much. I think that really captures optimism of the will, and really inspires our younger generation not to be limited by the past, but rather informed by the past to imagine and create a better future. I thank both of you for joining me this evening, for continuing to celebrate our relationship and the things that bind us rather than divide us. And I'll look forward to our continued conversation and the next iteration of this partnership next February for our Black History Month celebration between the Center for Bioethics at Harvard Medical School and our dear partners and family at the National Center for Bioethics and Research in Healthcare at Tuskegee University. Thanks so much, Professor Harvey, Professor Hodge, and to all of you for joining in this critically important conversation. Take care. Bye-bye.